Okay. I think we're recording. I've never been allowed to give a presentation and record at the same time, so bear with me. It's great to imagine everybody out there, and thanks, Josh, for putting this together. I look forward to seeing everybody next weekend at our Zoom meeting. Great. Oh, here we go. Okay. So what I want to talk about today is the prevention and reversal of frailty, and specifically the supplements and hormones to consider in this realm. For those of you who don't know me, this is who I am and where I practice. I'm a family doctor. I've been in practice for almost 40 years, which is kind of astounding. Yeah, I started when I was 5 years old, and that's where I can be reached. My conflict of interest is that the supplements I'm talking about, I do sell in my online store, and the hormone usage I'm going to recommend would constitute off-label use. So let's start with the learning objectives. I want to start out with talking about what the realm is we're going to discuss today, who's at risk for what exactly. The 3 key supplements and a few others that we can talk about in relationship to that, and what's the hormonal support we can give ourselves and our patients in this regard. My apologies to Dylan Thomas. Do not go feebly into that good night. And I think we can all agree that for ourselves, our loved ones, and those we care for, we don't want to be feeble as we age. We know that our hair is going to go gray. It's going to redistribute itself a little bit, but we don't want to lose our faculties, either mental or physical. We don't want to be eating a liquid meal with a spoon. That's not what we want to get to. On a more objective level, this kind of physical deterioration that often comes with age is really costly. It costs the United States upwards of $40 billion a year just in hospitalizations, more than that, obviously, in other kinds of medical treatment. And I'd say more poignantly for me, and why I'd say I'm actually passionate about this topic, is that in the last 5 years, I've had 5 patients fall and break their hip. One of them died pretty soon thereafter. 3 of them are markedly impaired in their quality of life, their function, their independence, and only one, ironically the eldest of them all, has regained her full quality of life from prior to when she broke her hip. I invite you to think of people in your world that have broken their hip, and that's really the main common manifestation of this problem that we're talking about. To do anything about any problem, of course, you have to start with a high index of suspicion. And I think that the first thing we all think of is that anybody who's old, and really it is 50% of people by the time you're 70 and over. But muscle and bone deterioration and our ability to manage them start at the age of 30, start declining. So clearly, how do we think about it before the age of 70? And a good way to think about it is anybody who has any chronic illness, and so anything in the cardiovascular, renal, metabolic realm, and particularly those with any cognitive impairment. As you see, some of the mechanisms are the same. We think about frailty. When someone's underweight, it's markedly unrecognized. When people are overweight, we just think they're clumsy, but they can have marked muscle deterioration. Complaints of fatigue. If you have the problem of frailty or sarcopenia, which we're going to talk about, your muscles not only are smaller and not functioning well, they're not wired correctly to the rest of your body. For somebody who is in a state of frailty, for them, the stress, the physical stress of going grocery shopping and carrying bags of groceries is like what it would be for a more fit person doing a strenuous workout, you know, doing an Olympic lifting session for an hour and a half. That's what going to the grocery store is like for them. So for somebody who's always fatigued, first of all, that's going to create frailty because they're not going to do very much, but it can be a symptom, a sign that that's what is really underlying their problem. And of course, think of it in any menopausal woman who's not on hormone replacement therapy, and quite particularly if she went through menopause early. It's easy to confirm, actually, and I'm not going to recommend that we can do these fancy body scans, but that just results in a delay when really the testing in your office can be quick and easy by testing muscle function rather than its mass. You test muscle function of the upper extremity with hand grip strength measurements. The device is called a dynamometer, and it comes with age-related norms, or you can easily get them off the internet, and somebody gives their maximum squeeze and holds it. It registers the maximum force they've applied. I usually have people do it twice, and you want them in the upper, ideally the upper third, but we'll take the upper half of normals for their age. More important for their ongoing life quality, though, is the function of their lower extremities. And I think, although there's many tests for this, the best one is a simple timed up and go. All you need is a chair, a hallway, and a second hand. And the person gets up from the chair, walks 3 meters, turns around, comes back and sits down, and you want them to do it in less than 10.85 seconds. You know, some of us are thinking, well, that's really easy. You could do it in 3 seconds, but it's amazing how much people slow down when they're insecure for good reason about their ability to maintain their upright posture as they walk. So there's tests for walking speed, sit to stand, 5 reps in less than 30 seconds. I like the timed up and go because it kind of includes both of those. Sarcopenia is really what we're talking about. Frailty is just about being in decline and seeming like you're not going to survive the trip around the block. But sarcopenia is more technically a loss of muscle mass, quality, and strength. The muscle size diminishes, and particularly the size of each of the kinds of fibers measured independently, type 1 and type 2 fibers. But the compromise is greater in the type 2 fibers. That relates to their quality, and strength is lost because the orientation of the muscle fibers within the muscle and their attachments to their point of exerting force are changed in sarcopenia. And so what they've got isn't as much, and it doesn't work as well as when they were younger and stronger. And I think it's easy to recognize that the main contributors to this condition are nutritional and physical activity, you know, diet and lifestyle. But there are also compromises in the neurologic function relating to the muscles. Hormonal changes in levels and changes in sensitivity to hormones vary with age, and immune factors. And what I mean about each of these more separately, there's a reference for this. So besides the muscle fibers themselves degenerating, the neuromuscular connections are degenerating because the impetus to keep them healthy, one of them is brain-derived neurotrophic factor, which you are probably aware keeps our cognitive function viable as we age. And it's all about living a good life, getting enough sleep, getting enough exercise, eating well, and doing the kind of brain games that Josh told us about last year And I think he's going to go into that area a little bit this year too. Brain-derived neurotropic factor doesn't just keep our brain vital, it actually has direct input into our muscular system. And there's a local version of it, if you will, a ciliary neurotropic factor that also responds and declines with age, responds to the promoting factors as BDNF does and declines in the same way. So as I said, not only do our hormone levels decline as we age, but the effectiveness of those same hormones declines. I think we're all aware that we get a little bit more insulin resistant as we age, whether we like it or not. Androgens, estradiol, growth hormone, vitamin D. Our levels are lower and our sensitivity to those levels diminishes. So what we have doesn't do us as much good. There is also changes in our immune system. So we accumulate over our lifetime an increased burden of reactive oxygen species just by the virtue of aging and going through another day, but also a greater lifetime exposure to toxins. And actual immune dysfunction. So the inflammatory markers that are noted to increase with age are most studied TNF alpha and highly sensitive C-reactive protein. So those two both go up as you get older, and they each, by being high, have a catabolic effect on muscle health, causing and including damage to the mitochondria and DNA. It becomes quite complicated. It's, if you will, a perfect storm where we have a lot of factors contributing to a loss of muscle strength and performance in just by virtue of what happens with aging. And we have a lot of factors that contribute to the degradation of that muscle quality and function. So perfect storm, that's the bad news. The good news is there really are a lot of points of intervention. And that's what we're going to kind of talk about today. So I think like almost any problem that we talk about in this wonderful organization, diet and exercise are going to be the main contributors, the main factors we need to attend to. And, I think of this talk as dovetailing with Tommy's talk. I meant to say that earlier. And I hope that he's primarily going to cover the exercise, rely on him for that, and really more about diet than I'm going to. And this is hopefully just going to be enough repetition to make it clear in our brains and stick there, and not enough to be boring. So exercise, yes. Diet. Diet, as we know, we pay attention to the 3 categories of macronutrients. Fats are important primarily as sources for key vitamins, which interact in the nervous system. Vitamin A, vitamin E, well known for participating in neurological, cognitive health, heart health, and neuromuscular health. Carbohydrates become a little bit more important when we're talking about maintaining the health of our muscles, because carbohydrates are key to maintaining sufficient insulin levels, but really the insulin signaling that's going to happen in regards to the muscle health. And protein, when we get to protein, well, it's complicated. This is where it gets more complicated for older people. I don't need to tell anybody in this organization, but when you're putting the protein on your plate, the best protein for you is animal protein. It's complete. It includes all the essential amino acids that we need. And you see in this slide, a lot of good varieties of complete animal protein. I would comment, remember I said that one of the problems are in the immune, one of the areas of problems is the immune system, where there's increased inflammation as we age related to toxins. And a fish that size is the perfect size to make you think they're safe, but to actually be containing mercury. So it should be a little tiny tin of sardines, or a nice big wild-caught Alaskan salmon, which also contains mercury. So you need to monitor it. Even if your patients tell you that, yes, I eat animal protein, I can almost guarantee, bet money that they're not eating enough animal protein. The basic federal recommendation is somewhere in the range of 1.2 grams per kilogram per day. But really, if you want to be active, it's more like 1.5. And if you want to rebuild muscle, it can be all the way up to 2 grams per kilogram of dietary protein. Even just starting with the basic federal guideline recommendations, that's 30 grams of protein 3 times a day. So I think it's good to know and to be able to tell people what 30 grams of protein is, because how many people tell you, yeah, I have an egg for breakfast? Well, to get to 30 grams of protein, you need 4 or 5 eggs, depending on their size. You need 4 ounces of hamburger. You need nearly the whole can of tuna. It's not easy to get 30 grams of protein. It's not easy to get this much protein. And they'll tell you about it because once they've chosen that animal protein and put it on their plate, they're confronting the challenges of chewing it and digesting it. And to chew the food, we need good gum and dental health, and digestion, of course, after we've chosen the meat, cooked it, chewed it, swallowed it, we have to be able to digest it. Chewing oral health obviously is key, and people know they should floss and they should go to the dentist. Anyone who tells you they're getting their teeth cleaned more than twice a year, they likely have gum disease. Or if they have a very progressive dentist, they can actually culture the oral microbiome and tell you, ooh, you've got bad germs in there. I can't really remember offhand the name of that test, but I'll look it up before we talk next weekend. What I do in that regard is just suggest to people as they're older, knowing that the oral microbiome also deteriorates with age, is to suggest a product called Dental Sidon. It comes in a toothpaste and a mouthwash. It's made by the company that makes the oral microbials called Biocidin. This is not the, we're not really in the supplement section quite yet. We're getting there. And hormonal support. So estradiol and somewhat progesterone are responsible for maintaining the health, vitality, and resilience of mucosal tissues everywhere, including the mouth. So the ability to maintain chewing force, effectiveness throughout life is somewhat dependent on all these factors, and a good reason for prescribing estrogen in menopause. The digestive support. It's no secret that as we get older, our digestive forces decline. And it's a little bit debatable which portions decline. You can test for digestive support, and this is really kind of any of the functional medicine. You know what? I forgot something I wanted to say about chewing. A reason to support chewing is it's not just mechanical. We all learned in medical school, it also promotes the production of salivary amylase lipase to help us with digestion, which comes next. But it also increases the amount of brain-derived neurotropic factor in the saliva, and that has direct access and neuro input to the hippocampus, which is where we maintain our memory and so much of cognitive health. And that same brain-derived neurotropic factor, as we said, provides input to skeletal muscle. Okay, so I didn't want to miss that point about chewing. It's not just to get the food down there, it's actually to help maintain your brain and your muscles. Okay, so now you swallowed the food. Are you digesting it? The different parts of digestion are stomach acid, which for most people declines with age. You probably need more Prilosec as you age, not because you're making more stomach acid, but because your motility is impaired. So most people as they age don't make enough stomach acid. And for some people who want to do this in a testing kind of progression, they might start with betaine HCl, which is the supplement version of stomach acid. It typically comes in 600 milligram capsules. The protocols, they take 1 with each meal for a couple days, then they take 2 with each meal for a couple days, and then they take 3, and they get to the point where eventually it's, they create some warmth in their stomach. I've never had anybody have anything like heartburn or reflux from taking betaine, but they'll feel some warmth and then they back off. What's not clear with aging is whether our ability to produce digestive enzymes is compromised. But if you make less stomach acid, you will make less digestive enzymes. And that is something you can measure on the functional medicine type stool testing. I use a company called GI Map, which is one simple specimen covered by Medicare. So there's a lot of digestive enzymes, but what I suggest for most people who want to keep it simple is to get a combination, something like Digestzymes by Designs for Health, which has betaine HCl and digestive enzymes in it, to take 1 or 2 before each meal. And then I tell them, I'm not attached to this brand, I'm attached to the ingredients. And anybody who's going to make a product that contains both betaine HCl and digestive enzymes, it's probably great. Now what? Here's what I got. Okay. All right. Sorry about that. So Digestzymes by Designs for Health. This is a great combination digestive enzyme. The big emphasis on protein is a little bit obvious, like protein is muscle. And so all the components of dietary protein are what we need to build more protein. But the most important component of meat protein in this conversation is an ingredient called creatine. If there were ever a supplement or a medication that should be put in the water, my vote is for creatine. So creatine in our bodies, it's stored primarily 95% in skeletal muscle. The second largest depot is in the brain, but it's also in the liver, kidneys, testicles, which is where it's manufactured. But everywhere it lives, it's involved in the process of maintaining cellular levels of ATP. Like we all want that, right? Especially in our muscles. Becomes creatine phosphate and then goes on to participate in the ADP, ATP back and forth shuttling. We rely on creatine to have sufficient ATP in our muscles. It's synthesized. You can either, it is part of meat itself if it gets through your digestive tract undisintegrated, but it's synthesized in the liver, testes, kidneys from dietary arginine, glycine, and methionine. Methionine really just in meat. Glycine, if you've ever listened to Chris Masterjohn's video presentation about that, it's great. We're all deficient in glycine. We don't eat enough meat off the bone. Maybe some of you do. Luckily, though, it is available as a dietary supplement. And yes, I'd like to put it in the water, but since we're not going to do that, I would like to include it in the list of the 3 crucial supplements when we're thinking of our patients and our own neuromuscular health. It's probably about the most studied supplement ever, as are most things that relate to athletic performance. And creatine improves not only our lean body mass, it has been studied to show improvements in both sprint strength, types of exertion, aerobic and anaerobic, and it just improves overall exercise ability and performance. It also, handy little side effect, has been helpfully studied found to be helpful when studied in cardiovascular disease, stroke, depression, particularly after cardiovascular disease, but other cognitive mood-related issues, musculoskeletal pain. So think of it in your fibromyalgia patients. Renal failure. So if you go on the internet, creatine looks a lot like is related to creatinine, and it's cautioned for renal patients. But a study recently out talks about the judicious use, proposes the judicious use of creatine in chronic kidney disease, because of course muscle wasting and sarcopenia are part of that condition. So giving creatine in such a way that it helps the patient but does not raise the creatinine is advised. And there are promising applications for it in neurodegenerative disease, which my particular interest, I have to say a little bit more about. So I'm talking about 5 neurodegenerative diseases. Vegetarian memory is a problem, and short-term memory is improved in those who have a daily supplement of creatine, but they really just studied it in vegetarians who are, of course, woefully deficient in creatine. In Parkinson's disease, it not only boosts the muscular strength, and weakness is one of the early complaints for a lot of Parkinson's patients, but it seems neuroprotective somewhat as well cognitively. In Huntington's disease, it reduces oxidative stress and measured DNA damage is reduced. In ALS, the results are a little bit more conflicting, but it does appear to be moderately neuroprotective. And in Alzheimer's disease, it's interesting because it's mechanistically very viable, helps the hippocampus, my goodness, directly, because of promoting BDNF. But it is also in amyloid plaque. So people are cautious saying, is it helping promote amyloid plaque? And since one of my goals in treating Alzheimer's is preventing the accumulation and helping the body safely metabolize amyloid plaque, great, it just liberates more creatine. So that's great. And I am eager to talk to Dr. Dale Bredesen about this, because I'm going to propose he include this in his protocol. And if he hasn't, maybe he has a reason. So I'll let you know. I'll try and do that this week. Dosing for sarcopenia is pretty easy. The product that people are looking for, and so this is number 1, that is number 2. Digestive enzymes is number 1. Creatine is number 2. Creatine monohydrate, a lot of people make it. It's people get a kick out of it because it's in the bodybuilding part of the supplement section of your store. It stirs into water. It's palatable. You have to keep swirling it while you drink it. So if you were training for competition and you wanted to really optimize your creatine effect, you would load for a week or 2 at 20 grams per day. But I just start people at the chronic level, which is 5 grams per day, which in every product I've seen is 1.5 teaspoons. But look on the package. The dose will always be calibrated to give people 5 grams a day. And if you are exercising that day, to take it before, during, you can put it in your water. I put it in my water to drink while I'm on the erg, or after exercise seems to have some additional benefit. If you're not exercising, still take it. It's good for your brain. The final supplement I want to really stress is, and this one is a little bit variable, with people who are sarcopenic and going to the grocery store wears them out, it's going to be really difficult to tell them to do an exercise program. And I'm hoping that's part of what Tommy talks about is, graded lesser and greater exercise, but getting the exercise to happen can mean making it less painful to them. So there is a gene, there are many genes that talk about the muscle damage vulnerability that an individual might have to taking statins. Some of those genes specifically talk about delayed onset muscle soreness, getting really bad muscle aches after you exercise. And the supplement that is useful in that situation is D-ribose, which helps with anyone's ATP recovery after exercise. But for people who have this gene, they'll get less muscle soreness and the amount of perceived exertion will be less. It'll just seem easier to exercise, a little boost. It's like caffeine is good too, but the carriers for caffeine make it so that you have to urinate in the middle of your exercise, not so great. D-ribose also lowers levels of creatine kinase, and that's one of the reasons it's been touted by cardiovascular nutrition-oriented doctors. And it may reduce, in some studies, perceived pain. So those who with fibromyalgia who you want to get to exercise, or people who are just weary, D-ribose is really helpful. It is also a palatable powder, and you can dose that more variably. And I just usually tell people to take 5 grams, but that they're not in any danger if they take more. Of course, the other secret to getting it to happen is to exercise with friends, make a running date. Of course, you're going to show up for it. I don't recommend running really for people my age. Do something you love. You know, that's me on our lake when we had water in it. And I just have to put a shout out to the TRX. So exercising in a class is really good. The TRX system I find really adaptable to this set of patients and to this era. It's cheap, less than $150. They have, this is not really a TRX strap system, I think, but it's a similar suspension trap system as the one shown here. You can put it in your suitcase and carry it with you when we go to a seminar together next year. You can take it out in the backyard and throw it up over a tree, or you can throw it up over the top of the door, the anchor in your study, close the door, and you can do a 5 or 10-minute set of difficult push-ups, because of course you're doing it, it's easier because you're doing it at this height, but it's more difficult because the ground is not steady beneath you. So I wish I had bought stock in the TRX system before the pandemic started. I'm going to take a little pause, see if I can make that happen, and I'll be right back. Take a break yourself. Okay, recording, I think, back at it. I want to say, as you tell your senior patients to consider investing in a TRX for their home, and there's a lot of videos on the TRX website, have them choose the videos that are meant for seniors because they're a little bit more graduated. Whey protein and insulin I want to comment on because it's around the time of exercise supplement that's widely recommended. But gee, if I look on Twitter or I pay attention to low carb, I know that dairy in and of itself is a weight gaining booster. And that's because whey protein boosts insulin levels. But what's important to remember about insulin is, it helps the sugar go into the cells, it helps us accumulate body tissue, but muscle is included in that. But remember the role of insulin again. And if you've forgotten, Tommy did a great podcast for Nourish, Balance, Thrive, that it's an anti-catabolic hormone. So it is one we want. It's, remember, in aging muscle, it's this balance of buildup and breakdown, and insulin is essential if we want to do any building of hormones. So as I said, older people have a greater degree of insulin resistance, so their baseline insulin levels might be high enough to help them accumulate greater muscle mass, but it wouldn't hurt to boost insulin, particularly eating either carbohydrates around the time of exercise or specifically whey protein. Now this window of opportunity question is a little bit debatable. So right after exercise, nutrients go into the muscle to replenish glycogen. Glucose goes into the muscle without the need of insulin. That window is probably only about a half an hour after vigorous exercise. So getting together your whey protein shake and having it an hour after you exercise might be the best way to try and get nutrients into the muscle cells using a boost in insulin rather than avoiding it. Insulin's a hormone. We're going to talk about hormones too, but before we get to hormones, let's pay a little more attention to just some supplements that I kind of assume everybody is on and not particular to sarcopenia. Kind of think everybody should be on some high quality omega-3. Nordic Naturals is in all the stores or one of the pharmaceutical grades. Beyond that, I'm not very interested in other purveyors of omega-3s. Healthy omega-6s in your diets, nuts, and well-prepared nuts, not cooked in nasty fats, and in general, gently cooked fats, and avoiding the use of vegetable oils. I don't need to tell this crew that. And your favorite anti-inflammatory, whatever it is. And I'm going to tell you a little bit about a new one that I've just been introduced to doing cognitive work and the research program with Dr. Bredesen, which we've wrapped up and are in the process of writing up. In our body, one of the substances we make to help us reduce inflammation is something that has this really roll off your tongue name of specialized pro-resolving mediators. We don't make enough of them clearly, and they've been packaged into supplements called SPMs. And you won't find this at Rite Aid. You won't even find it at health food stores. This one you're going to have to buy from a physician supplier of pharmaceutical grade supplements. And for many of the patients in the study, and I would say personally, I think it has more effectiveness against osteoarthritis pain than curcumin, which is the other one that's been best studied. Also, SPMs reduce markers of inflammation, but it's hard to isolate that from what I've seen because, of course, I never just do one thing in isolation. Okay, hormones. Insulin is the bridge to this hormone talk, and we've said a little bit about insulin. Vitamin D. We have vitamin D receptors in all our muscles, and it has been, it's become clear over a long time as we've been looking at vitamin D levels that it needs to be supplemented in older people. Our skin, not only does it not tan as wonderfully as it did when we were younger, it doesn't absorb much vitamin D. And if you're north of the 35th parallel, and that's like Los Angeles, you have at least some months out of the year where your shadow's really long. Your shadow's taller than you are. No one's going to get vitamin D from the sun, but older folks are definitely not going to get it. So supplement with vitamin D. I'm fairly confident that 40 nanograms per milliliter is a bare minimum, and upper limits of 60, 80, 90 are proposed for different purposes. DHEA has some documented benefit in the setting of exercise. Anecdotally, it's an energy booster and has an interactive effect in boosting insulin as well. Growth hormone, what? Estradiol and testosterone. And I say though, what about growth hormone? I'm going to say a little bit more about growth hormone. Okay, so those first three are hormones you can totally tweak yourself. Obviously, like insulin, just eat carbs. Enough, not too much. Maybe whey protein when you exercise. Vitamin D, get it up to that level that we talked about, over 40, maybe higher. My favorite vitamin D product is Da Vinci A, D, and K, because it's an optimized single capsule of D that has enough A in it that your patients who are allergic to eggs and can't stand liver don't get enough of. Carrots don't count. Vitamin D and 500 microgram dose of vitamin K, which is great for cardiovascular health and cognitive health. DHEA, as I said, is synergistic with exercise. The dosing is 5 to 50 milligrams a day over the counter. For people who are anxious about its partial conversion to estradiol and testosterone, the keto DHEA form really does avoid that. And here's the surprise, is that growth hormone is actually a tweakable hormone. So it has been studied administered to people, and I've certainly heard anecdotal evidence and anecdotal fears and evidentiary fears. It's not really ever been well managed from my reading of the literature to be given as a supplemental hormone, and it declines with age, but you can boost it yourself. So heat shock proteins, we don't make as many as we age, but if you work out hard, you will make some. If you get really hot, you will make some heat shock proteins. This is why saunas are great for longevity and been well studied in Finland. Turn on any podcast by Rhonda Patrick. She almost always refers back to the Finnish studies. Deep sleep before midnight. I'm very curious about this. This was also in a Rhonda Patrick episode talking about vitamin D, but of course they strayed into the area of sleep. And it's not deep sleep per se, but in their reporting, deep sleep before midnight. So yes, you're better keeping farmers' hours, and you make more growth hormone from deep sleep before midnight if you have adequate melatonin. Those levels also go down past the age of 40. So I do recommend, in younger people, very judicious use of melatonin. In older people, if you can tolerate melatonin, it doesn't make you drowsy the next day, you're probably benefiting from that supplement. So the hormones that you need a prescription for, let's start with estradiol. Now, interestingly about estradiol, when I'm speaking to older women, I say, your husband, if he's got that nearly pregnant belly, probably has higher estrogen levels than you do. And we know that that's because belly fat, visceral abdominal fat in particular, makes aromatase, and aromatase converts testosterone, which this guy at 65 still makes a lot better than his wife makes estrogen. So his levels actually might be higher than hers. The optimal level for men, for all the purposes we're going to talk about of estradiol, are thought to be over 20. But for women, we're thinking that the level has to be somewhere 40 to 60. I've always heard it referred to as 40, but I just went to a hormone webinar last weekend and one of the speakers said 70. It was just one reference that she gave for that. But reviewing a little bit what we talked about before, estradiol, really valuable for gum health, really valuable. And that's intrinsic to chewing, mental, feeling good about yourself, and the ability to consume the meat protein we're going to ask people to eat. Estradiol also has a direct beneficial effect on muscle mass and strength, the collagen content in muscle, and it boosts mTOR, which helps our body synthesize muscle. Estradiol has a synergistic effect with exercise, which of course, we know optimal exercise does a little bit of muscle damage, and then the rest you take for the next 24, 48 hours helps muscle repair, and estradiol is key in that. There's questions about its effect on tendons. So we've made the muscle stronger, more effective. Estradiol's effect on the tendon is that it can make it stiffer. And if you have a really lax tendon, that's a benefit. But if you have a good tendon and you're making it stiffer and you make the muscle stronger, are you putting yourself at risk for tendon damage? And this is more realistically a concern in young women. It's why if you look at teenage sports teams, girls have a lot more knee injuries than boys do. Probably not pertinent to our population. So prescribing of estradiol, this is not going to be enough to get anybody started prescribing, but just in case you're thinking of it, we always do it transdermally. The North American Menopause Society has finally come around and said that estradiol reduces the risk of breast cancer, which is everybody's main concern, rightly so. But it was those oral equine estrogens with synthetic progestins that estrogen has taken the fall for. We always give it with progesterone, even if they don't have a uterus. Some progesterone has some likely muscular benefit and definitely cognitive and sleep benefit. We do some kind of breast surveillance. It does not cause breast cancer, but if you have a breast cancer, it will get it to grow, and just want to be on top of these things. And estrogen metabolite management. So whenever anyone's been on hormones for a little bit, for me, 4 to 8 weeks, I ask them to provide a urine sample. This test is not covered by Medicare, to see if they're metabolizing more down the 2, 4, or 16-hydroxyestrone pathway. They have different physiological effects throughout the body, and you can modulate those with supplements and diet choices. Happy to talk more about that if somebody's interested. So testosterone, getting to the men, kind of paralleling the loss of muscle mass. It starts around 30 or 40 years old for men, and the loss may not really get started for others until their late 70s. So there is, and it's not all men, it's 30% of men. And I would say that in my practice, which is interesting, of course, which we'll get to in a minute, I'd say it's by far greater than 30% of men in that age group that have low testosterone. And when you have low testosterone, you have an increased risk of all these conditions, and particularly the last 3 we're talking about, pertinent to exercise and muscle mass. We have receptors everywhere for testosterone. In our brain, our ability to think, sleep, supposed to be a comma between sleep and mood there, libido, and it's not erections, that's vascular endothelial health, but someone's desire to have sex, male or female, may have a lot to do with their testosterone levels. Testosterone affects metabolism, both of protein synthesis and our ability to metabolize fat. Stem cells stimulation, again, part of response to exercise and recovery from exercise, and erythropoietin. Muscle mass and strength, and bone density, not bond density. I really can't say anything about your stocks and bonds. I'm really just talking about your bones. Testosterone prescribing. I really just do transdermal, and when someone's been on transdermal for a while, we may move them to intramuscular because it's more convenient. You can do it weekly or sometimes even every 2 weeks. When you do the labs for testosterone, measuring the total testosterone is deceptive. This is where I was saying, particularly in my practice, I really encourage people not to eat a bunch of sugar. I don't have anybody whose hemoglobin A1C is over, I don't know, 6.2, something like that. I'm shocked at some of the levels that people actually generate before they reverse it. As you get older, and as your insulin sensitivity is maintained, or in fact improved with a lower carb diet, your sex hormone binding globulin goes way up, and the amount of free or effective testosterone that you have, male or female, obviously the numbers are different, varies widely. So you always have to measure both. I measure dihydrotestosterone, both dihydrotestosterone and estradiol put somebody at greater risk for prostate malignancy, more so than the testosterone itself, which can make a malignancy grow, but not generate an increased risk. I do get a PSA, liver function tests, and hemoglobin and hematocrit because of the erythropoietin. I have one patient in the Midwest who regularly either gives blood or has a phlebotomy to address that problem, because for his brain health, he wants to stay on testosterone. People need to have their prostates checked. And then depending on the results of the tests listed above, we may do something to block aromatase or block 5-alpha reductase. So aromatase helps them make more estrogen. 5-alpha reductase gives you more DHT, not to mention more secondary sex characteristics, that's great, but at an advanced age, that means more baldness. So I always have it compounded because it's a more organic preparation, and start with levels about 100 or 200 milligrams a day. If in the testing we want to inhibit aromatase, we can do that with a number of natural factors: quercetin, resveratrol, zinc. Zinc is like testosterone's best friend in every way. Helps you make more testosterone if you're a man and helps you metabolize it. Might use both progesterone and aromatase inhibitors for men who are making too much estradiol. Use progesterone more if they're also having trouble sleeping, and letrozole more if they're feeling great. I just don't want their estrogen to be above 20 or 25. And then the supplements that can reduce 5-alpha reductase and the levels of dihydrotestosterone. Just a few miscellaneous comments as we wrap up. So there's more hormones, great, but I think we have enough tools in the toolbox to address this problem with the hormones and the supplements and the diet and lifestyle measures that we have. Of interest is that ACE inhibitors have been helpful, and even in a sedentary population, but also in an athletic population. Let's not forget the long list of medications that impair or reduce muscle quality and strength. Steroids, and this is primarily referring to oral steroids, but even potent topical steroids have been associated with muscle and bone loss. Furosemide, all nitrates, calcium channel blockers, statins, obviously. Beta blockers really interfere with the ability to exercise, and thus you won't get the fruits of exercise. And then metformin, and Tommy and I went back and forth a little bit about this. My favorite local oncologist, whom the long-standing PAH members met half a dozen years ago, Dr. Dawn Lamont, she likes her cancer patients to be on metformin, but she does have them time it, so it's quite away from exercise. But she thinks 12 hours is enough. Is it? I don't know. Tommy thought maybe it needed to be 24 or more. I'm not sure. But metformin, of course, inhibits mTOR, and which is part of what we rely on for building muscle strength, but it's not the only thing. So if your patients have good reason to be on metformin, that's fine. And in that similar vein, caloric restriction, same thing, works in the same way when it extends life, but at what cost of quality of life? On the bright side of all this, you know, that perfect storm, every perfect storm comes to an end, the blue sky, the sun comes out. You can get, with just 2 or 3 sessions of exercise, personal physical training weekly, there's been measured gains of up to greater than 50% in just 6 weeks. So imagine if they do all this and keep it up as lifetime habits, we really can see a reversal of sarcopenia in a lot of people and a gaining of strength. It just is hard to get them going because they're slower. I've just thrown at the end here some favorite sources. Some of them I cited in the talk, some of them I didn't. There's really interesting literature about it. Thank you very much for paying attention to this and hopefully putting up with not too bad technical prowess. May we all get together next year and go dancing. Good to see you all. Okay, now I want to exit and I want to stop recording. Bye, you guys. See you next weekend.